Sarab Chabra, the next speaker. We'll be speaking on amniotic membrane for repair of spontaneous scleral melt in Marfan syndrome.
Good morning, everyone. Thank you for being here for this morning session. I would like to present an interesting case and an interesting management before you of usage of an amniotic membrane for the repair of a spontaneous scleral melt in a patient who presented with Marfan syndrome. This was an adolescent male who presented with a gradual progressive diminution of vision in both eyes since the past 8 years, worsening over the last 3 years. There was no history of ocular trauma or surgery. Visual acuity at presentation was 6/60 both eyes, best corrected to 6/24. IOP of both eyes was within normal limits, and as expected, the older brother had similar complaints. On ophthalmic examination, the anterior segment had iridodonesis with loss of peripheral crypts. The pupillary area was partially phakic, partially aphakic. Superionasal lens subluxation was visible with phacodonesis, and there was a myopic fundus with no peripheral treatable lesions. On general examination, all the features were suggestive of Marfan, such as a tall stature, long face, thin fingers, an increased arm span, and the cardiologist reports showed a mitral valve prolapse with moderate regurgitation. As there was no refractive improvement, a bilateral pars plana lensectomy with anterior vitrectomy was planned with suturing of the incision site. Both eyes were operated by the same surgeon. The left eye was operated after the right after a gap of about 10 days. The post-operative course, the right eye was thankfully uneventful, but the left eye was far from that. On post-op day 0 in the evening, the cornea was clear. There was a 1 millimeter hyphema. The pupil was round, but the peaking had just begun, and the IOP was low. On post-op day 1, peaking had increased, hypotony was observed, and similarly the disease progressed on day 2 and day 3 with severe hypotony noticed and spontaneous scleral melt posterior to the surgical wound site. The patient was taken up for emergency surgery. Intraoperatively, scleral rupture with adjacent areas of thinning was noticed, and underlying uveal tissue was visible. All the abnormal overlying thin conjunctiva was excised, and an live amniotic tissue graft measuring 26/8 millimeters covering the entire area of thinning was implanted and secured with 8-0 Vicryl sutures. For post-op medication, the patient was advised topical and oral medication including oral steroids, tapering doses starting with 1 milligram per kg body weight, along with fortified topical antibiotics, cycloplegics, lubricants, and oral cyclosporin 50 mg twice a day. These are the post-op day 2 images. The eye was stable, the graft was in position, and the visual acuity was 1/60. And thankfully, at 1 week of follow-up, the globe was stabilized, the graft was well taken up, no recession was noticed, and the IOP was maintained. At 6 months, the scleral wound and the site of rupture were stable along with the conjunctiva over it. Best corrected visual acuity was 6/12. Highlights of Marfan's: it is an autosomal dominant disease affecting fibrillin gene present on chromosome 15. This abnormal fibrillin causes axial myopia, scleral thinning, and mechanical stretching, which leads to progressive rupture and perforation. There have been few reported instances of spontaneous scleral perforation. Generally, scleral thinning, the most commonly used methodology for treatment is scleral patch graft, and there have been a few reports of late dehiscence of a sclerotomy in patients of Marfan's. In this case, there was no recurrence noticed over a long-term follow-up, and amniotic membrane is a good candidate for such patients as it lacks immunogenicity, promotes epithelial growth, and has high regenerative capabilities, much more than scleral patch grafts. Thank you so much for your time.
So excellent case this. So now coming to the AMT, so was it freshly prepared?
So the amniotic membrane, sir, it was a live amniotic membrane. The institution has a high number of obs-gynae loads, so a live graft was available.
Okay. And now coming to the last follow-up. So vision was 6/12, the peaking was there. So why not you went for the 4th row pupilloplasty to make the pupil round and regular?
So the patient was satisfied with the visual outcome. So the patient is still on follow-up. Once we are sure that there is no recession and there is no chance of any the recession.
Vertically, what was the means? It must be a 6 millimeter optic size only, the IOL?
Yes. Yes, sir. Sorry.
Optic size was 6 millimeter only, no?
Yes, sir.
So little bit of phakic area was visible.
Yes, sir. But the patient was satisfied with the vision, as that portion is usually covered with the eyelid also. So.
Okay.
You have used suture
Yes, sir.
for tucking the amniotic membrane. Why
Yes,
not you have used glue, which would be better result?
Sir, in this case, the first consideration was the saving the integrity of the sclera. So at that time, sutures seemed the best, and so using sutures had the best probability of the graft not moving around with a long term the graft being held in place long term. So as it was an emergency surgery, sutures were the first choice.
Is it sterile scleral melt or infective scleritis?
Sir, sterile.
Sir, how do you know? You have done any testing for that one?
Unfortunately.
Microbiological testing was done?
No, sir.
No.
Thank you.